Hello, my name is Lieutenant Lauren Waters. I have been a nurse for 9 years and involved in healthcare simulation. Previously, through working with Navy corpsmen at A School, we worked with about 3,000 students annually and with multiple different types of simulation training, including mannequins, task trainers, and various immersion scenarios. I will be discussing how immersion simulation is used for head-mounted display with focus on uses in the nursing community. In 2016, New Media Consortium predicted that VR technologies will be adopted in the higher education sector within 2 to 3 years. This has not happened for nursing school, but why is that? The later slides will go more in depth of the current pros and cons of virtual reality and head-mounted displays. I will briefly discuss common terms and definitions most relevant to the presentation. Current state of consumer available hardware and software, including the limitations of both, how stress is used in immersive and virtual reality simulation training, and how they can affect learning, and the potential uses for the nursing community. I do not have any disclaimers or affiliations with the products discussed during this presentation. Virtual reality will be the main topic of immersive simulation for this presentation. However, many different forms of simulation are immersive and try to encapsulate all 5 senses to heighten the realism. Presence is the term used for virtual reality to mean how the learner feels about being in the virtual environment, and if the learner can equate it to the real world experiences. A higher sense of presence equated to better learning outcomes. While virtual reality is not a new concept, the creation of head-mounted displays has allowed a boom of opportunity for combining hardware and software to be consumer-friendly. Stress inoculation training is a version of simulation training that can involve immersion and/or virtual reality, but is accomplished through gradual, controlled, and repeated exposure to a stressor. The goal behind this exposure is to desensitize and build resiliency. One of the first commercial uses of virtual reality came from a program called Second Life. It grew in potential for educators to use virtual reality as a learning platform, bringing clinical structure and collaborative learning using real-time visual displays and allowing users to create avatars to represent themselves and to facilitate reflection with the trading of stories between participants. An instructor can model the expected behavior, but then allow the learner to take an active role in the social environment. While immersion simulation using virtual reality head-mounted displays is becoming a popular tool in clinical settings, it is difficult to break into the current nursing education model. It would be impractical to expect IV starts to be perfected if the student cannot see a sharp IV needle in their own hand. However, there is potential use for virtual reality to experience the correct time to start an IV when confronted with an aggravated or combative patient. Using this technology as a tool for critical thinking and for stress inoculation with increased presence. A still current use of immersion simulation training is the computer automatic virtual environment, typically seen as an oversized 3-direction screen, using 2 or 3D graphics and imagery for learners to either be immersed in a reality-based scenario or in environments not easily imagined, such as space or the cellular structure. The learner is still immersed, but with a different learning objective. It does have a major benefit over head-mounted displays, with some cave systems being able to accommodate multiple students at once and using them as a teamwork environment. What would be the opposite? Non-immersive reality, which is basically computer training and serious gaming. The first and most popular consumer device for virtual reality head-mounted displays is from the company Oculus Rift, and it was the first to become consumer price available. Prior to 2015, a head-mounted display could cost up to $45,000, but be as cheap as $1,300. While head-mounted displays are good for eye tracking and interfacing with haptic tools, the haptic tools actually allow the learner to engage using sensory immersion of sound, touch, using gloves or wand hardware to provide the virtual reality avatar similar actions. You move your hand with the wand and your avatar in the virtual reality also moves in the same direction. It is not ideal for task training without appropriate equipment. As seen in the picture A, this learner is using a laparoscopic trainer, or surgical trainer, while using head-mounted displays and earphones. In the picture B, you can see what that learner is actually seeing. Notice the participants next to her are only using the laparoscopic trainer to see what the laparoscopic machine is displaying. The different learning experience is very evident. The learner with the head-mounted display has a very view-restricted environment with distortions on either sides of the peripheral. However, the learning objective is to use the laparoscopic trainer for a surgical procedure. The learner next to her is doing this only with the 2D screen in front of him. Both are doing the same objective, but using drastically different means. The person with the head-mounted display is using sound as distractors, as well as the peripheral and other environmental distractors, including the operating room nurses in the foreground and in the background. Virtual reality outside of nursing has shown significant results with users to explore worlds either reality or fantasy-based. Within the healthcare community, this allows educators the ability to provide scenarios with hazards and obstacles, and the learner can visualize and determine the correct path, such as a tight operating room or the best place to stand during a cardiac arrest. This is performed by the user either physically moving or eye tracking to determine if the learner was able to identify all of the hazards. Virtual reality also allows the opportunities for simulations that are either too expensive or potentially unethical or unfeasible to perform, such as an operating room fire, which can cost in a simulation environment up to $90,000, and maybe 8 participants can be involved, versus $45,000 hardware and software that, while only able to train one at a time, is usable unlimited amount of times. The best use is helping the learner be immersed and given options similar to serious games and algorithm choices. The increased presence and stress distractors can provide the educator and learner the necessary feedback for delayed or incorrect choices without real-life consequences. While head-mounted displays in virtual reality becomes more commercially popular, increased amount of content provided by filmed environments and the use of 360-degree cameras, all the true immersive experiences the user is able to have, and the ability to look all around them, and it has the potential to be more involved in nursing education, involving a true inside look at operating rooms or busy trauma bays. However, the ethical and privacy considerations will probably be one of the biggest barriers to this avenue. These pictures show a real-life learner imposed over what he is seeing through the head-mounted display simulation. Note, he is also engaged in sound and visual stimuli. The haptic wand tools allow interaction with the virtual reality, and he is able to manipulate that environment for the learning outcomes. And I'm sure even if the learner is aware the scenario is involving a fire in the operating room, the increased presence, even though he cannot be burned, allows the stress to test the memory retrieval during the simulation. The link between stress and learning is still debated. However, one theory is memory is facilitated when stress and stress hormones are experienced within the context of the simulation-based education, leading to a habit-based learning which doesn't easily translate to critical thinking in high-stress situations. Including the appropriate time to pre- and debrief the learner for optimal retention and resiliency training can allow stress to be a very effective tool for immersive simulation training. I apologize for the poor picture quality, but what this graph is illustrating is the time of the rise of stress hormones in the basolateral amygdala, an area central to emotional learning. The rise of stress hormones that prime the brain for encoding of memory and therefore learning correlates to the general time frame wherein debriefing is usually performed, which being considered using virtual reality, a high-presence simulation would require an expert-level pre- and debrief for high emotional eliciting simulation. However, simulation-based educators can exploit this adaptive behavior if stress is metered properly. There are many studies proving and a few disproving the effectiveness of stress inoculation training. Some areas that have already used stress inoculation training include sports, industry, aviation, and military. In a study conducted by DARPA, virtual reality was used to simulate real-world training. The participants conducted a weapon search of a house. While not a healthcare or nursing, the study shows a higher success rate and more accurate completion in not only the physical psychomotor portion, but also the cognitive, with non-VR participants conducting house searches multiple times and retracing steps and going back to the same locations. When applied to nursing, high danger for learner, such as an ORFI or active shooter hostile worker, we can see how this study can use the recognizing of physiological arousal and enhance performance during simulations. The emotionality of material being presented has a critical factor for enhancing or impairing coding. Remembering stressful experiences or the context surrounding them is an important adaptation tool for survival. With this, we can see how the affected skills differed from the cognitive and psychomotor skills required out of the simulation training. The participants who used virtual reality was shown as to be a higher effective during the actual scenario in real-world situations. With nursing, this can help save lives and even build resiliency for a stronger nursing career. The picture displays a popular program for ACLS algorithms for code scenarios. The learner is using the head-mounted display and single haptic wand for environment manipulation to choose the correct intervention, and the patient would be able to display real-time response, either positive or negative, with feedback. Studies have shown the introduction of deliberate stressors, those that interfere with the five senses or elicit strong emotional response, into the simulated environment has shown beneficial effects. That is to say, those stressors were not haphazardly thrown at the learner, but used as tools to build a strong connection to the immersive environment. Keeping the stress hormones in mind, an immediate debrief would have little effect, as the participant is still in a fight or flight mode, performing approximately 30 minutes after the onset of the stressor, and coincided with the classically described cortisol release shown in the previous graph. The appropriately timed feedback would lead to an improved long-term retention of skills. One study did show findings where after immediate use of high-stress simulation versus a sterile simulation, those with stressors performed with more confidence and capable difference of simulated code management. But after 6 months, without repetitive practice, both groups had a minimal difference in performance. Virtual reality technology can provide the opportunity for all key stressors and participant feedback to be easily tracked and marked and used during the debrief. The participant can even review at home after the fact to continue self-reflection in the learning process. The virtual and computer engineering communities continue to show improvement with technology and crowd display technology. This is similar to the breakthrough seen in Lord of the Rings. If you've seen movies prior to this, you've seen large groups, and you've noticed that there's basically one group repeated throughout the screen. But with Lord of the Rings, they were able to overlap independent moving, computer-generated crowds, giving the realism of the orcs about to storm out of Mordor. Sorry for the nerdy analogy. While this advancement is used more for anxiety and agoraphobia stress training and cognitive behavioral feedback training, this can be used in the nursing community as well. With multiple independent avatars in the immersive environment, while you are in increased presence and able to manipulate the environment, each of those avatars would be able to react to you manipulating that environment. Even if currently single user interfacing, the software is being introduced and improved for group avatars within the same simulation. Increasing the amount of learners who can interact within the immersive simulation goes back to the beginning of the potential of virtual reality, becoming a cooperative learning platform. Having immersive environments of rare or difficult to recreate patients, such as burn patients, death, confrontational patients, or coworkers or family members, or CBRNE events. This allows a facility to develop a program similar to standardized patient scenarios, but with head-mounted displays virtual reality, increasing that presence. The difficulty is the current products do not allow recorded images to be manipulated by the learner to show different algorithms. But with increasing artificial intelligence interfacing being able to recognize speech patterns, there is still the potential for standardized patient scenarios to be used with head-mounted displays, allowing the learner to experience the high level of presence. As discussed, resiliency training within the aviation and military community is still growing and refining using virtual reality. The potential for nursing should be as unlimited. With high-stress scenarios of confrontational family members or coworkers, failed intravenous access during a code, or patient demise could be a few of those high resiliency needed training gaps. I appreciated the phrasing used in literature review by Ott and Freena. Head-mounted displays not make learning to occur, but they can be used as a medium to access simulations in which learning may take place. The future of education using virtual reality is still growing within the nursing community. It is being supported for some aspects of high-risk scenarios and cognitive behavioral actions, yet there is so much more potential for nursing. When I polled a few of my coworkers, it was difficult for them to imagine the use of virtual reality for either nursing school or when first starting in their chosen fields. However, when I gave a little more information of how differently any of us could have reacted the first time a patient yelled at us for not getting their pain treated quickly enough, or a physician using non-productive language when their order was not performed stat while you were taking care of an entire emergency department or 6 other med-surg patients, how differently you would have been able to react if you had first experienced this using VR and learned coping skills and resiliency training instead of going immediately into flight or fight. My coworkers were then able to understand there is no true limit to how VR should be used. Thank you for listening and hopefully learning from this presentation. I enjoyed understanding how far we still have to go with the nursing education community and technology integration. I'm Lieutenant Waters, and I have appreciated your time.